Hello everyone, Dr. Carlo Jer, emergency physician with DrER.tv, and of course this ED Exit Video Pro. Again, I post videos directed at the medical health professional or people wanting to learn more about medicine in general. This is actually a clinical case that I saw today. And we actually been posting 2 previous videos today about the interpretation of chest x-rays. So I thought this was great. On that first video, the first lesson was to the initial overall review is this a normal or abnormal x-ray? I mean, right there's so many abnormalities. I mean, just grossly, this is all fluffy, kind of fluffy everywhere. The heart size seems to be a little large. Remember, the second video talked about the cardiothoracic ratio. The heart should not be more than half of that thorax length. So you can see that there's definitely an enlarged heart size there. So grossly abnormal x-ray. The other things, there's wires present here, there's monitors, this is a sicker patient currently on monitor, and things like that. And lastly, the other thing you should be able to notice, well, you notice because I know what's wrong. You can see a little thing right here, and that's the airway, right? The trachea, which we saw in the second video. But this is an endotracheal tube, and I'm gonna zoom in so you can see. So there's like a line within the line. You see the line right here? And then even though this is the wall of the trachea, you can see the tube line right there. Right there. So the tube actually has a metal wire in it so that people can tell that it's there in case it's not penetrated enough or whatever to be able to see in detail. So let me tell you about this patient. This is a very obese patient who presented with 3-day onset of cough and congestion, has started to produce some phlegm over the weekend, and the primary doctor ordered some Citromax, some Z-Pack to take yesterday. She spent the night having a lot of trouble breathing, not sleeping well, and then today it had altered mental status, AMS, and they called the EMS. EMS got there, and walking her from the bed to the gurney, her oxygen dropped to the 70s, and then she became increasingly more altered to the point where she wasn't breathing well and she was kind of unconscious. So they started BiPAP, and this is pressure on ventilation through a mask. So every time she breathes, the machine pushes air in, and when she exhales, it lets her exhale. But it's a non-invasive mode of giving respiratory support to the patient. However, when she arrived to the ER, she was not doing well. She was removed from BiPAP, and the oxygen went down to the 50s, which is terrible, right? And so immediately we know that patient needed to be intubated, and potentially could be a COVID patient. We don't know. So we have to mask up and get ready, and we used the gyroscope for intubation. It was no problem, even though she was morbidly obese. The gyroscope allows you to see the structures through a camera, and she was able to be intubated. So then, how's her ventilation? What's her breathing pattern? Well, her pH on an ABG was 7.02 with a PCO2, and this is crazy, 111. Normal should be at 30 to 40. So this is extreme CO2 retention. Basically, she's not blowing off the CO2, making the CO2 convert to H and bicarb, which essentially leads to acid production, which brings the pH down, 7.2, very acidic. So respiratory acidosis, or respiratory failure in this case. So when you intubate these patients and ventilate them, you got to make sure that the respiratory rate is large. I mean, 16, 18, 20 per minute, and that you have enough inspiratory volume so that you can really blow off that CO2 and bring down the acidosis. And then, of course, patient did not have a fever, but you can see the x-ray. It's got all this fluffiness here and here. That's indication of pneumonia process. But good thing, COVID was negative, flu was negative. So it looks like it's a regular kind of pneumonia. Patient obviously actually ended up dropping her blood pressure even after like 2 liters of fluid. So we have to start pressors which is IV medications to bring the blood pressure up, and we start at level fed. And she's going to the ICU because she's very sick. She ended up also with a high white count of 33. Normal is 10.5. So it's very, very high white count, indication that patient not only has sepsis, but with the hypotension, the high white count, she has severe sepsis. And because it started pressures, that brings actually into septic shock. So this is a patient with septic shock. And you can see how the case progressed through home and into the emergency department and ultimately here. And again, going back to how to read a chest radiograph, the initial overall approach, very abnormal x-ray, has things that shouldn't be there, like lines, endotracheal tube, enlarged heart, all this fluffiness over here. But then you go to the systematic approach. Remember, we talk about the penetration. You cannot see the vertebral bodies behind, so this is not a very well penetrated x-ray. And that's just a side effect of the patient being so obese. You can't get a good penetration. Inspiration is actually remarkably good for this kind of patient. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 ribs. So normally you want to see 11. So this is actually not terrible for the patient. And then of course rotation, you can see here, actually we talked about that. That's the clavicle there and the clavicle here. So yeah, it's kind of in the middle, it's not rotated, so we're good. And that's it. Hope you enjoy this video. See you.